Hey, welcome. Hope you can hear me. I'm Jose Guillen. I'm a colorectal surgeon here at UNC, and it's my pleasure to invite you all to what I think will be an exciting session on establishing a registry, the tips and tricks to it. We have an international panel of very experienced individuals working in this space. I'm going to briefly introduce them. We're going to go through 3 presentations, and each will have a targeted focus. Will give their perspective about their own registry. The first speaker is Melissa Aronson, who is the manager and senior genetic counselor of the Familial GI Cancer Registry at the Zane Cohen Center in Toronto. She's also an associate professor at the University of Toronto. And what Melissa is going to talk about is what are the criteria for enrollment in her registry. Melissa Aronson, please.
Okay, great. So I'm just going to share my slides. Hopefully you can see them. And I can't see, there we go. Okay, I have a strict 10-minute rule to stick to, so here I go. Thank you so much for the introduction. I'm going to give you a bit of background on our registry. So as you know, I'm from the Familial GI Cancer Registry. It was started in 1980 by Dr. Zane Cohen, who's a colorectal surgeon, and Terry Burke, who's a social worker. And they were seeing a lot of FAP patients, which is really the only syndrome we knew about back in 1980. But eventually Steve Gallinger joined. He had an interest in pancreas cancer, and I joined in 1998 with my interest in gastric cancer. And so the registry really sees all hereditary GI cancer patients. This is a picture from the Leeds polyposis group back in 1985, and there's Terry over there. And our group has grown in 2001, and this is 2010 at the Zane Cohen Center. There's Dr. Cohen over there. And not all of the people here work in our registry. A lot of people work in IBD, but we're a really big collaborative group. So we work with a lot of different disciplinaries. Not everybody works on a day-to-day basis with us, but we consult with a lot of different specialties. On a day-to-day basis, we have 3 genetic counselors, we have our admin assistant, and then we have volunteers. So who do we enroll in the registry? This is really my question to address. And we enroll people both with known hereditary GI syndromes and those that we suspect may have a hereditary GI syndrome, but their testing either came back with no variants or VUS. So our registry is located in the province of Ontario in Canada, and all the stars represent different clinics in Ontario, and we try and recruit from the different clinics in the province, although we are known to recruit even from other places in Canada, but because our registry is so large, we're trying to keep it a little bit more manageable within Ontario. These just show some of the numbers of the families that we've recruited in the past. So you can see we have over 1,000 patients with known APC mutations. We have over 2,000 patients with known Lynch syndrome. And then it drops off a little after that. So 100 MAP, CDH1 cases, JPS cases, and then even less for the rare genes like GREM1, GAPS, POL-E, MSH3, we only have 1 family. And for these families, we send an update every 2 years to ask about their updates on their screening and any cancer diagnosis. We also ask about relatives, any new family members, whether people have been tested, because we also want to track who in the family has been tested. And we invite any relatives with one of the syndromes into our registry. We also store biospecimens like blood and saliva and tumor in our repository. Oh, this doesn't seem to want to, oh, there we go. So what type of patients would you want to recruit into registry with known syndromes? Well, these are some of the questions I came up with. Do you want to keep it narrow? So just focus on FAP, or just Lynch syndrome, or just hereditary gastric, or do you want to be broad? In Ontario, we're actually just starting a registry with all hereditary cancer syndromes, but it will be much less data than we collect in our FGICR. Who do you want to recruit patients from? Your local area, or are you able to go much wider? That really depends on personnel and your budget. How can you make it easy for the genetic clinics to recruit? So if it's too hard, no one's going to help you recruit patients. So you have to really think of ways to make it really easy for them. And also, can patients enroll themselves? Is there a way for them to do that? Is there any benefit to joining the registry? Why would people do this? Why would clinics put themselves out to help enroll if there's no benefit? So I'll show you some of the things that we do. And ultimately, what's the purpose of your registry? What do you want to learn? Like, do you need blood on all your Lynch cases? Do you just want to know about cancer? Do you want to know about treatment data and so forth? So this is just a picture of our database. It's a huge, really beautiful database. And if we have time at the end, I can show you a bit about that. We also do education nights for our Lynch patients and FAP and MAP patients. So every other year, we have about 150 carriers come to learn about the new things about Lynch syndrome. We do symposiums for health workers in the province, just to give updates on what's going on in hereditary cancer. We came up with screening forms for all the different syndromes. We can give them to patients or their family doctors as an easy one-step tool. We've come up with pamphlets. So basically, we're trying to do something a little step above a clinic so that people will want to enroll with us. We also have one-on-one matching, so like a buddy system, we have a support group and so forth. We also recruit patients that don't have a hereditary syndrome known. That's a little harder to define because that could be a monstrous task. So we essentially recruit people who are diagnosed really young, like let's say under 35 with colon or gastric cancers that have no mutation identified, polyposis cases that came back with a negative panel result, strong family histories, as you might want to define it, either Amsterdam. You'd have to really come up with a criteria, otherwise you'll just be overwhelmed with families, unless of course that's what you want. And synchronous tumors we also recruit. So we have a criteria that we would be comfortable with given our personnel and the size of our registry. And some of the things you might want to consider if you're going to recruit people with no hereditary syndrome, which is harder to define than people with known pathogenic variants. Consider your budget. Do you have a budget? Consider what study and materials you think you might need. So if you're looking for new genes, do you need a triad? Are you going to be recruiting the parents? Do you need fresh frozen tissue or RNA if you're going to be looking for new genes? Do you need to collect pathology information and chemo information, or just really basic information that would be easy to do data entry on? Is this a population-based registry? So I was also part of the OFCCR, which is part of the NIH-sponsored collaborative family registries. And that was a time-limited population-based study where we recruited all colon cancer patients in our province, all the high risk and moderate risk, but only 25% of the low risk. And it's actually still going on, but really just for updates. And then other things to think about, if you are recruiting these patients and you find new pathogenic variants, how are you dealing with that? Can you call the family back and let them know about the results? All of this should be thought through and put into your consent forms. Of course, the research is important, and these are just some of the many, many articles that have been published with collaboration from our registry. And I'm just going to mention I'm also part of another consortium. So I've been part of, this is now my third registry. This one is at Sick Kids, headed by Dr. Uri Tabori, and it's focused a lot on CMMRD. So we see we have over 200 CMMRD patients from around the world, and also other replication repair deficiency syndromes. So that's where I'm going to stop. I'm under time to give to others, and then we can hopefully answer questions after.
Wonderful. Thank you so much, Melissa. We're now going to move over to Francis Balaker, who is the gastrologist. He's the head of gastrology department at the Hospital Clinic of Barcelona. And he's going to talk to us about what are the minimum essential data points per patient registered. Francis. I think you're muted, Francis.
Yeah, no, sorry. Hi, Jose. Thanks for the introduction, and thanks for the CGA for the opportunity to share this very interesting webinar with you guys. So I'm gonna briefly talk in the next 10 minutes. So Jose has been very clear about the time limit. So about my experience on behalf of a large group of gastroenterologists that have been doing collaborative research in the last 20 years, and we have developed several collaborative studies with a very, very focused idea, and we have called them EpiColon and Colon Prep. These are the two main studies and initiatives within this large group of professionals. And this story started in the early 2000s, and with the first registry, which was called EpiColon 1. And over the last 20 years, as you can see in this slide, we have updated this registry and making grow and grow. And basically this collaborative setting has developed clinical and translational research, and the pillars of this collaboration has been to have the people that asking the right questions, which is something that we're gonna talk about later. So you need to clearly focus what do you want to solve. Second is to know how to use it, so how to get the data, how to analyze it. That is very important. To only get data with a clear focus, this is sometimes is not very useful. And finally, you need the patients, and you need the samples, and so you need to figure out how to collect all this information. And I think that a very important point of the collaborative studies and registries is that all this effort need to lie on very important values. And I think that trust, generosity, and transparency are very important when you are setting up a register or a collaborative study. And I think that you need to have these values in the registry. So basically, very briefly, as I said, these registries had very focused questions. So EpiColon was born with a very simple question, and was, what is the prevalence of familial hereditary syndromes in Spain? That was in the as I said, in the late 90s. And afterwards, after this very important question, several questions came afterwards. So how can we characterize these high-risk conditions? Basically, we have worked on Lynch syndrome and psoriatic polyposis syndrome. Can we identify new syndromes based on what we have? Can we develop biomarkers for early detection? And so after the 3 versions of the EpiColon, which has been very successful from a publication point of view, so this has created this large network. And the Colon Prep was born in the late 2010 with also a very, very focused question. So what is the best strategy to screen colorectal cancer? And this is a large clinical trial that is comparing fecal immunochemical test with colonoscopy, that we're going to have the results probably in less than a year. And you know that this is a very, very important topic these days after the publication of the Nordic results evaluating the colonoscopy. And after this, several nested studies have developed within this Colon Prep study. So basically, I'm trying to ask the question that I'm trying to tackle is, what are the minimum essential data points that you need when you create a register? And I'm going to give you my perspective based on my experience and experience of the group. But as I said before, and also Melissa touched this very important point, is you first need to ask, what is the purpose of your registry? What do you want to do with your registry? And I mean, from a very simplistic point of view, I mean, you have 2 options. So one is, I want to collect clinical data from a certain condition, a disease, syndrome, carriers of a mutation, but I'm not sure what I'm going to do with it. So I'll figure out later. So I'm going to get data, as many data as I have, and then I'm going to ask the questions. And that would be, for example, I want to register all the Lynch syndrome cases or all the hereditary syndromes that I can see in my clinic. And then we'll see what can I do with it. And then there is another option, which is the one that we have mainly does, is I have a very specific question to answer and about a very certain condition. I just don't want to get as many Lynch syndrome carriers in my registry, but I want to know exactly, I need the data to know what is the risk of colorectal cancer, for example, depending on the mutated gene, or depending on the quality factors of the colonoscopy, or other factors. So in this case, you know exactly what you want. And So at the end, it will always be a balance between too much information. So if you want to get so many variables, probably it's going to be unlikely to get all the data for all the patients. Your collaborators will be mad at you because you are asking so much information. This is a very high workload, so it needs people to keep the registry updated. And but the good thing is that you will have a lot of data, so you can ask many questions. On the other side, if you ask too little information, you only have key variables. That is very easy. The collaborators will be happy because they only need to put some demographic data. But at the end of the day, you will not have probably enough data to answer the key questions that afterwards you will ask yourself. So to me, the answer to what is the minimum essential data points to be registered depends on the question that you want to answer, and or at least the questions that you can anticipate that you will answer afterwards. And as a summary of what I said before, if you're not sure about the questions, that's going to be easier for your registry. You can register demographic genetic testing. I'm a gastroenterologist, so I'm going to give examples of endoscopy surveillance. You can register if the colonoscopy is performed or not. Not yes or no, but also the dates. You can register the polyps, if there was polyps or no polyps. That makes it easier. Your collaborators will be happy, and sometimes it's a good start to make collaborative studies from zero. So you get a picture of what you have. But you're responsible afterwards for the success of the project. So you have to think in advance what are the questions that you're going to try to answer. The downsides of this option is that, as I said, there will be always missing variables that you're gonna need to answer those questions. And this has recently happened to us. I mean, for the KPIs of colonoscopy. I mean, one of the last studies that I was involved is evaluating the quality of colonoscopy in Lynch syndrome. If you only get the date of the colonoscopy and if there were polyps, and you don't know if there were adenomas, how were the adenomas how was the colonoscopy performed, then you cannot answer the key questions that you want to face, right? And so it's very likely that you need to go back to your collaborators and say, okay, guys, I need more data. So you have to now go back to the clinical data and get how were the adenomas, or how was the colonoscopy complete or not, etc. And that is painful, as you know. And the option B that I mentioned is, okay, now I know exactly what I want to answer, no? And that is very good in terms of you know exactly what you need. You can define your variables very well. You can get exactly what you need for your questions. However, and also there will be a low likelihood of going back to get the new data. So so it's once and done, in the sense that your collaborators will need to fulfill all those variables at once. As I said, the risk is that sometimes you get too excited and you ask for so many variables that it's difficult to complete. And also, I think that a very downside of this is that if you are asking a very focused question, then you miss the opportunity to ask other questions that might be important. No? And this, for example, if you focus on Lynch syndrome and the colonoscopy and the risk of colorectal cancer, eventually you can ask for, okay, what happened with gastric cancer? Which is, and you will not have the data, right? So what if this happens, that you need more data out of the registry? I mean, there are some basic tips. I mean, I think that it's very important to explain to the collaborators the purpose of the getting new data. You need to plan ahead what you're going to ask. So don't mess. I mean, don't ask the similar data twice to complete your data points. And also, if you go back to the data, think of other possible projects that might be in the future of your interest. So as a conclusion, I mean, and then maybe we can talk about this later in the discussion, but I think that is very important if you're starting from scratch to define the purpose of your registry, to spend a lot of time thinking of the essential data points and the variables based on the current evidence, but also try to think in advance on what may happen in the future. Keep your collaborators updated, and if you need to go back to get the data, do it smartly. And that's it. Okay, I just want to thank all the collaborators from these studies over the years. I'm somehow speaking on their behalf, and I'm very grateful. Thank you very much.
Thank you, Francesc. Wonderful presentation. I just want to move on to our next speaker, who's Jennifer Weiss, Associate Professor in the Division of GI Medicine and Hepatology at the University of Wisconsin. She's a director of the University of Wisconsin Gastroenterology Genetics Clinic, and she's going to speak to us about how does your registry interact with other hospital or system-wide existing registries or databases such as EPIC in terms of downloading data in order to minimize duplication of effort. So we'll hear from Jennifer Weiss, and then we'll come back for general discussion. Jennifer.
Okay, I think I'm unmuted now. So thank you for everyone for joining us today. And I just want to start off by saying, so I'm actually kind of on the opposite end of the spectrum as far as starting a registry. So I think this will be a really good, show a good variation of fantastic registries and what our goals are and what we want to attain and where, and then I'm going to present probably where a lot of you guys are currently at. So the initial state of my registry was 2011. I was a fresh-faced young faculty member and starting the GI Genetics Clinic at UW, and said, I need to start something. I want to start this registry. And basically, Melissa and Francesc gave a very good point of the first question of why. Why are you starting this registry? And for me, the first start was for clinical purposes. It was, I want to start making sure I'm following the patients that I am seeing in my clinic and making sure that they are staying up to date with their surveillance and there's just so many things they need to do. I need to stay on top of this. So the first thing I did was just register for IRB approval for a clinical database, which was very easy to do, to just kind of register it and get permission to keep a Excel spreadsheet on a secure server. So the advantage was I wasn't really registering patients where they needed to sign a consent form because it was for clinical purposes. So I could just keep a list, a spreadsheet. But the disadvantage is that if I actually wanted to do a research study or answer a research question, I would have to write an IRB for every new protocol or new study that I wanted to do on the patients. As far as data storage, I stored it in a secure folder in our Department of Medicine server. It's password protected, meets HIPAA guidelines, so there was no issues with that. But prior to the Department of Medicine's adoption of Citrix to be able to log in virtually, I had to actually physically be at that desktop computer in the Department of Medicine at my desk in my office to be able to even log in and get to that spreadsheet to enter any data. So that was a huge issue from a data entry standpoint. One advantage was that I could very easily customize my spreadsheet with whatever I wanted at the drop of a hat, but I had to enter the data myself. And so I just wanted to show some examples, and you don't have to really be able to read everything that's on here, but this is just an example of the kind of thing I started for patients with Lynch syndrome. So I started, you know, their names, their MRN, the first date of visit, what mutation we eventually identified in them, whether they had a history of cancer, how many colonoscopies they've had, what were the results, the EGDs. I mean, you get the picture. I was thinking I was going to constantly update this and keep adding to it. What, you know, oh, this person in number one had another colonoscopy in 2015. What was their results? And I would just keep adding and adding and adding. And with respect to FAP and attenuated FAP patients, it was very similar, except they had even more procedures with even more polyps and even more biopsies and pathology. So this just got really kind of out of hand very quickly, especially since I was the person who was entering the data. And I was also still seeing general GI patients in clinic as well. I mean, this just wasn't feasible. So fast forward to 2015. Thank God for Epic. And I know this is not something that everybody says on a regular basis because most of the time we're cursing Epic. But at least once we started having Epic, I started moving to patient lists in Epic. So this is the current state of my registry, which is really just my own personal patient lists that I have created in Epic. And I wanted to show this to people because everybody who has Epic can do this. And so really what this is, and on the right side of the screen, this is a brief picture of my lists. So I have just started a new list for any diagnoses that I see or things that I want to keep track of the patients for. So patients with check 2, colonic polyposis of unknown etiology, early onset colorectal cancer, FAP. I have HDGC, I have Lynch, I have the people who I have Lynch-like syndrome. And I have people who are in both lists. I have people who have check 2 and HDGC. So so this way, it's nice because I can create a new list. I can create as many lists as I want, and I can easily pull into the list. I can go into the list and say at a drop of a hat how many patients I have with Lynch syndrome that I've seen in my clinic. So I can just click on my Lynch syndrome list and I can tell Pete Stanich at the Ohio State that I have 200 patients on my list. Is that enough for you to want to collaborate with me? And I'm only picking Pete because I know I saw you on the call. So it's nice, and that way, and I can add and remove patients as needed. You have to remember to update the list, but the other issue is there's really a limit to what variables you can keep in this list. So you're limited to what Epic will allow. There's no IRB approval needed to keep this list in Epic because it is a clinical list. I can easily access it from any computer. Patients can be in multiple lists at one time, but again, you have to only customize to what is included and allowed in Epic, which really is not the variables that we are interested to answer questions about patients. So I can have their name, their MRN, their primary care provider, certain things like that, but not their mutation. You can share the list with others who also have access to Epic, so that's nice for purposes of other people kind of looking at your registry list. But again, you have to do manual chart abstraction to answer a lot of the questions. So because this is where we are right now, and it's a nice start. But if someone comes to me and wants to collaborate, all I can do is say, okay, to the IRB, I have 8 patients with juvenile polyposis syndrome and I apply, but then I have to do manual chart abstraction to get all the data that somebody wants for their study. So the next thing, future registry, would be using REDCap. And I think this is where a lot of people are. I think REDCap is going to be a really excellent tool for a lot of centers. Where we can create our own database within your center. But since multiple centers across the United States have access to REDCap, we can create very similar REDCap databases that can be then shared across centers and with each other. So the goals of this, of a future registry, would be ease of use for both entering and querying data. The flexibility to add new variables or forms over time, which I think REDCap allows. The applicability for multiple hereditary syndromes, so you can start with Lynch syndrome and then potentially add more syndromes with different variables for the syndromes that you are collecting data on. And it will, as you set it up correctly, allow you to share de-identified data across health systems to merge data. And you can then also run data pulls for both research and clinical uses. So the major considerations for us in trying to start up this database, this REDCap database, are the IRB, because we have to do one for retrospective as well as then prospective IRB data collection, which we're going to then need to have consent from every patient. We have to figure out if we need an umbrella IRB, or will we then need separate IRBs for every new project that we want to share our data for, collaborate with other centers. We will definitely need to use data use agreements to be able to share the REDCap data across centers. So that we'll have to work with the university for that. And it will likely have to be de-identified data that we are sharing across systems. And then the other consideration is who is going to do this. So do you need like a full-time FTE to enter the data? Is it going to be me who's entering the data? Is it going to be a genetic counselor or somebody, some other faculty? Do they need salary support? I think these are big considerations for us right now. And then the other major issue is how do you get the data and how does it where does it pull the data from? So from Epic, we can get a number of things, but pathology is a separate database and we would need natural language processing to pull some information versus manual chart abstraction. Genetic test results are scanned in our institution. Provation is what we use for our endoscopy software, and that's separate. Epic is creating their own endoscopy software called Lumens. So if somebody's using that, that might be easier. Is there a state tumor registry that we want to pull information from? And then Care Everywhere is the outside records that are in Epic that we can see, but we have to figure out if we'd be able to pull that information into the REDCap database also. And then we would love to, way in the future, link to a biorepository. But what I do want to end on is there is hope. So Dr. AJ Bansal at KUMC is starting to work on this, and he is in the very early stages of creating a REDCap database that we are then starting to share formats and templates among multiple healthcare systems. We are going to be having a meeting at CGA. So if anybody's interested in learning about what is happening and is in the very early stages of starting their registry and wants to use some of these templates so that you can share or start sharing, please let us know and join us at CGA. And I think I was the only one who went over my time and I had less slides than everyone else.
Wonderful, wonderful, Jennifer. Thank you all. I'm going to just pose the last question and we'll go from the top. The question is, what were or are the top 2 challenges that you faced in establishing and maintaining your registry? So we'll hear from Melissa first.
So I would say the challenges are funding. It's hard to get funding for a registry. And luckily, those of you who know Zane Cohen, he's an excellent fundraiser. So we do get funding, soft money to fund it, and it's been going for over 40 years, so he's very good at this. But it's very challenging to pay for staff and admin and paper and everything else that you might need to run a registry. The second thing I would say that's hard is motivating people to send patients to the registry. People are very busy in the different clinics. They often don't want to approach their patients about research or registries. And so we do all of the work. In other words, we don't ask our collaborators to send us information. We just ask for a name and contact, and then we do all the legwork, getting all the path, entering all the data. That's all done on our end. So we don't ask for much, but even for what we do ask for, which is send us the names of your carriers, is sometimes a challenge. And so I think it's just about building your, trust among the people you work with and giving back and building your reputation as being a good place to work with. That's what maybe would motivate others to work with you.
Thanks, Melissa. How about Francis Belager? What are your challenges over in Barcelona?
Yeah, I would summarize first is that to keep the register alive. I mean, that's been a really a struggle, and that's why I think in Spain, only in the GI field, we more than a register, as I said before, we have done several collaborative studies within an established network, and each study, I mean, has somehow used a register, but it's been a different venture every time. But this has been the way to solve the problem of having a established and well updated register like Melissa's, for example, and this, I mean, doing these very focused studies has been the way of solving this issue. And the second one is funding. I mean, as Melissa said, I mean, it's so difficult to get funding to keep a register. I mean, and that would be very nice, but we still rely on the very motivated gastroenterologists and the rest of the team that are willing to go to the data and get all the data necessary to do the registers and to do the studies. So so these are the two main challenges.
Thank you, Francis. Jennifer?
Yeah, so I would 100% agree with funding. And I would even go so far as saying that for me, doing the pieces it's not impossible. I know who to go to in my university to help me build the REDCap database. I know where I can have the data stored at our university. I know places that I can apply potentially for pilot funding or things like that. But then you need funding that's going to keep going. So funding that's not just a one-time source. And then that funding is what I would use to fund a person to actually like be the director of this and manage it, and enter the data and make sure that things are being done appropriately and quality checks and things like that. And that is the biggest thing for me, is I don't have the person to help me do this and to keep it going. So that's the one thing that's really been holding me up right now is having the person and making sure that they are there to continue it, because if they leave, you have to find someone to replace them, or somebody else who's going to put in that time, because it takes time.
Excellent. Well, I thought those were fantastic presentations and delivered as expected with such a variety of experiences and insight. I'll ask a question to get it started, and so many questions we can ask, but from the beginning, Jennifer, I guess you're at the earliest phase here of it all. You intrigued me with the usage of the EPIC patient list. So if I was starting a registry, I would say, well, that seems like a no-brainer. You're going to get this list. It's my list, and I can probably have access. I'll know what's in there. But if you're ultimately going to be going to REDCap, which seems like it's the most interactive and usable, you can download from EPIC into it. How does would you want to, if you had time and you had to do it over again, would you spend time on that patient list, or would you just have the FTE get right to REDCap? What do you suggest?
I would probably have the FTE get straight to REDCap. And then as you're seeing patients in clinic, you can easily just create a list and add somebody to that list if you know their diagnosis. And then you can easily share that list with that coordinator, so that they can then look at the list and know that they're entering the right patients. So I would have them start with entering stuff in REDCap, and then you just create the list and update it as you're seeing people in clinic.
That's great.
And I have to be honest, I have not looked through all of the variables that I can have in my lists in EPIC yet. I just really started right away with just their name, MRN, their PCP, and then it'll tell me whether they're still alive or not, which is helpful because they're all alive. Thank God I check that regularly. But I think there's probably some more things that I can get from there too.
Great, thank you. Any questions? I don't see anything lighting up there questions wise.
Somebody had their hand raised. David.
Hey, yeah,
David,
hey,
David, how are you?
Hey, good. How are you? Great presentation. Thank you all. I just wanted to comment about, the funding aspect that everybody's been talking about. And we don't have a Zane Cohen here, but we're also lucky that we do have, long funding and philanthropic funding that it's an endowment. So it's not something we need to keep asking for more money, but it's something that we can use just the interest of. So that's I think very helpful. But the other aspect of it is, and it's an abstract that one of our coordinators, Lisa LaGuardia, will be presenting the post on at CGA, where we looked at the downstream revenue that a registry brings to the hospital system. Because our thought of doing that project was to show the hospital administration really how much revenue a registry can bring into the system. And it's a huge number of procedures, surgeries, imaging, and pathology, and it's something we all very much know, but actually putting a number on it is difficult. But when you do put a number on it and you show it to the hospital administration, that's something that can be very powerful then for the hospital to pay for the coordinators. If you're not thinking about a registry only as a research tool, which we know it isn't, but also as a clinical, really important clinical way of how we provide care. We actually were able here at the Cleveland Clinic to have the hospital operations start paying for some of our coordinators. And that's because they realized how much revenue it's bringing into the system.
Thank you very much, David, for that insight. We look forward to that abstract at CGA. Thank you. I think Pete is. Hi, Pete.
Yeah, just thanks, guys. Great talk today. Really helpful. We're kind of at Ohio State in a similar spot to Jennifer. And I would kind of second, I have a very similar, clinical list, and I started keeping when I started doing this, where I just like pop all those patients over. The trouble that I've had is I can't find a way to go from like that list to like an Excel. So my poor resident had to like hand type like 250 MRNs the last time we did a study, which is like brutal to go from one computer system to another. So is there some way you can export that? Like, has anyone been able to successfully do that without spending 2 days like typing out numbers?
So I have also had to do the same thing. In the beginning, I could like cut and paste, just copy and paste from Epic into a Word document or Excel. Since then, I don't know if it's because they've changed their security parameters or what have you. I'm not able to copy and paste certain things out of Epic, or most things out of Epic. So yes, it is. That's the trouble I'm running into. I do know, I mean, when we do get to the point where we have a REDCap registry, I think that you will be able to pull that stuff from there. The biggest issue for me is the people who pull the data into the REDCap registry are in the IT department, and so then I have to pay them, and then there's things behind the scenes that would have to be done, and then you just say, oh, why don't you just find a med student, have them do it. So
Hey, Pete, one thing that might be helpful that we have our own database. We have the Collagen database that we use here, but a function that's built into Epic is the slicer dicer function. Have you heard of that? And that's something that can help export lists and diagnoses into Excel.
yes, that's a great point. I totally forgot about that.
Mm-hmm.
Okay, I've heard of it. I don't know much about it, but I'll look into it.
Danielle, do you have a question, Daniela?
Hi, everyone. I'm Danielle Marino from the University of Rochester. I actually was coming on to say, check out Slicer Dicer. It's on my to-do list of things to check out. I also haven't fully checked it out yet, but I know that it can export reports of patient lists, and I think that could be really helpful for a lot of us. I just want to thank you all for great talks. And Jen, I think you really described like a lot of the challenges that we're all facing, and it's kind of refreshing to know that I'm not the only person that's struggling with these things. But one of the main problems is like all these systems that don't talk to each other. So we also have our genetic testing results scanned into the media section of Epic, and we're working on trying to make it so that it's a discrete variable that can be put into the results section, and then you can actually pull reports by gene mutation. And so, but everything takes forever to happen. They have to build that, and it takes 8 months for them to build anything. So that's something we're trying to work on, to have them actually build it into the results section, and then you can pull a report per gene mutation. And I think that would make things a lot easier.
Yeah, I think that is a huge, oh, sorry, go ahead.
No, it's a quick question, Jennifer, for Daniela. Is that something that you'd be willing to share, your IT people? Is there a...
We are very, very early in this process, but as we make progress, I am happy to share with everybody how we did it and what we did to make it work. I'm sure there's going to be a million hiccups, but we're just starting with the meetings to talk about exactly what we need them to do, and hopefully we'll get there at some point.
Great.
That's exactly what I was going to say, is if a lot of people are using the same electronic health record, once people have solved each of these issues, you have to get permission from Epic and from your IT, but it is possible to then share what your IT did at your center with another center that also has the same electronic health record.
We need to just demand these things from the Epic people. Like, this is what we need to do our job. And then once they do it somewhere, they should be able to do it everywhere.
I was going to show, if you want me to show the database, I can do that. Do you want me to try, Jose?
Yeah, please, Melissa, that'd be great.
Okay, so we thought I can just share. I'll try and do this quickly. Can you see our database?
Yes.
So just to show you, we created our own, and we started with Excel as well, and then went to Access. and now we've advanced. But the problem was when you do a query, you often have to try and figure out all the different variables to talk to each other, and that was incredibly challenging. So we have a demographic page where we track date of birth, whether they're still living, gender, and all of that. So those are fields in our query. We track ethnicity, which is over here, so that we can see what their ethnicity is. And hold on, I'll show you 1 second. So we track ethnicity over here in case that's one of the questions we want to look at. We also track things like extracolonic manifestations, which would be hard just to pull out. So we check them off if there's a syndrome that we want to look at. Under our germline, we're able to track all the different germline results that we get. And then each of them have additional information. So we store the description, the consequence, the exon, all of it is separate so that you can study it a little more easily. And then if it was done on a panel, we're able to check off the other genes that were tested on the panel. And then if they had multiple tests, which they do here, we have a gene summary, which is able to track all the genes that they've had tested in multiple tests if the panels have been updated. We also track classifications. So for example, these are all different areas that people get referred in, but for example, for Lynch, were they referred in because they had an IGC deficiency or because they were MLH1 BRAF negative? So why are we seeing them to track, who gets referred into a clinic? And under medical record, so I'll just show you that under First Family Directory, we put in everybody in the family, and then we can easily just click this button that creates a pedigree for us, pulling all the information directly from the database. And if I enlarge it, you can see that it will come up showing our proband had colon cancer at 21 years old, and it shows PA, which means we have a copy of the pathology report. That's how we confirmed it. And it also shows a tally of all her polyps. So she had 2 adenomas and 9 hyperplastic and 11 serrated. And it's pulling that information from the medical record. So here is the colon cancer diagnosis. And then we also track, because this was created by colorectal surgeons, what type of surgery, we have the path number in case we need to access the tissue, histology, staging, all of that. And then in the surgery, were polyps removed? And we can track, how big were the serrated polyps? Were they proximal to the sigmoid rectum in case we need that for our criteria? We track IHC and MSI and somatic testing, and all this is developed over the years, which is, as Francis was talking about, new information. This is, we wouldn't have had it at the very beginning. And as we track all their procedures, which we do, so all their different colonoscopies, our computer is able to add up all the polyps from all the procedures to show, how many total serrated have they had over their colonoscopy life. And we can take this information. So if their last scope was in 2020, we have a place where we're able to say they need colonoscopy every 1 to 2 years. So their next one is due in 2021 to 2022. And then we can print up a little screening form for them saying, hi, your next screening should be here based on what you told us. So, and then after all that, we can query anything. So how many people have adenomas, more than 30 adenomas in a young person who has, Ashkenazi Jewish with medical records, who had an adrenal cortical carcinoma with FAP, and so on and so on. So any, query with any of the fields, we'd be able to figure out through our query process. It just takes a long time to enter it all. We have it down to science now, though.
Well, that's a great perspective to get from where Jennifer is at, which was probably you back, or not you, but
We were. I
back in
remember it
1980.
clearly. Yes.
Right. It's taken 40 years, but it's phenomenal. It's
Yeah.
it's gold. Well, Jennifer, so hang in there. You've got 4 decades to do this in. Any other questions from folks? We still have some time. I have a question for Melissa. Oh, go ahead, Colleen.
Yeah, hey, I'm Colleen Flay. I'm actually a pediatric gastroenterologist in Columbus. And I was curious if you guys have had real life experience in getting like multi-center REDCap data forms approved through IRBs, particularly with the DUA, because as pediatric institutions, we're trying to collaborate more just to get larger numbers of polyposis patients. And there's a pretty large international multi-center study that we're trying to get up and running, but is essentially on pause right now because our DUAs are all like stuck in legal, even with de-identified data that we can't, that are really having a hard time being able to share and collaborate because of legal reasons. I don't fully understand it because it's all de-identified. So I didn't know if you guys had experience with that or how to bypass that.
So I have recently, so the first thing I had to do was a study that we actually covered with Susan McFarland and Bryson Katona for juvenile polyposis syndrome. We couldn't figure it out. So I had to basically pull the data, create a spreadsheet in Excel, and then I had to send this. I was only allowed to send the spreadsheet as an encrypted file to Bryson. However, then he couldn't open it because it was he could open it, but he couldn't edit it. So then he had to have a med student copy and enter the data from every cell into their own spreadsheet at their own institution. So that is horrible, and I will never do that again. However, with Pete, we participated in a study on upper GI tract findings in patients with colonic polyposis of unknown etiology, and I don't know if he's still on, but it was fantastic. Like, we had a shared IRB, and then I just had a link, like a survey link that I would just click on. So for every patient, I would just click on that link. It would take me to the REDCap database that was actually taken care of by them. And I could just type in the information there.
And you did not need a DUA?
No, I don't think I needed a DUA because we seeded our IRB to their IRB. So it was, I mean, we got IRB approval, but it was seeded and everybody reviewed it all.
Yeah, Colleen, what we used is, it's called Smart IRB. And I'm not sure if it's international, but most, academic institutions in the US are members of it. And, a lot of it is like, I think not even like medical people, but like the rest of the university uses it as well. But just like Jen said, so the OSU IRB approved it, and then all the other places had seed review to OSU IRB. And then like a lot of places, there was like a little bit of paperwork, but it was kind of a short, short forms to fill out. And I agree, it worked pretty well. It took legwork, but not like years, like 6 months or something to kind of track it down. So that I think that is an option. And what we ended up using was a REDCap. And then you can, instead of like logging in everyone where you could just like dump an Excel, if you did patient by patient, you just need like an email address, and that was approved for us. So if you had like a big study with hundreds of people, that'd be a pain, but for like 5 or 10 or 15 or 20, like, I think it's not too bad.
Yeah. The other thing that I would advocate for in terms of creating a database is like, these patients are, as pediatricians, like, they have these diseases and we're often taking care of them in the pediatric institutions, and being able to follow them longitudinally in their care in a pediatric hospital, and then as they transition to adult hospital to kind of get a bigger picture, I think would be very cool as a, I don't know, bigger idea.
Great. We have a couple of minutes. A question for Melissa. You probably were not there when they had to make a decision at one point. I'm sure Zane and Steve probably were collecting gene positive individuals into the registry. But I saw that you specifically said cancers. So you're not registering family members that are affected, but I mean that are mutation positive but don't have disease yet? Or are
We
you?
do. Yep, we register everybody who's mutation positive, whether they have disease or not.
So it must be voluminous, right? I mean, is that, and only 2 FTEs are taking care of this?
We don't really even have a full FTE just for the registry. They do clinic and registry, but yes, and volunteers. You'd be surprised. We probably have about 5 relatives per positive case. So, and that's not bad, to be honest with you, like because most people can find maybe 2 or 3 relatives in a positive family. So, but after doing it for so many years, I mean, you know, we've registered a lot of the patients. So it's really just prospective families now that come up. So we have hundreds of families, but, you know, every year maybe we get, you know, 70 new positive families that we have to register and all their new kin.
Mm-hmm. Interesting. And Frances, the question for you is, it seems like your approach, as you pointed out, is really study specific, which is interesting. And it's sort of what we did back at MSK. But the challenge that you must face there is once you're done with that study, what happens to that database? You get a new question, you probably cannot really use those same patients, or maybe you do. Could you talk a little bit about that?
Yeah, so the problem with that is that we have been changing the database over the years, and actually I have to say that we have moved to REDCap lately, and it has worked very well in terms of collaboration and the database, and what we have done is, or we have tried is update the database as Melissa showed. I mean the same database, even if it was for a different project. So that because a lot of information doesn't change, and so that's been helpful. But yeah, the challenge has been that we have changed the database several times. So that's a pain, right? Because you need to get the data again and again. So that is definitely a challenge. Yeah.
I was going to say that's a good point, because we've had to go back. Like if someone says, oh, you know, we should mark who's an index case because you want to exclude those maybe, then you've got to go back to your whole database to figure out, you know, that data and enter it. So every time you add a new thing, it creates a mountain of work to go back and fix.
Yeah, Jose, maybe I had a question for Melissa, I mean, or for Jennifer, or Melissa, in the case of your register, so who have access to this data, and who can plan or propose studies with it within your registry?
So all of our patients sign a consent form saying that they're willing to be part of continued research, anonymous research. Our database, our consent says as long as our ethics approves it, we can collaborate with anybody. So as long as there's ethics approval, and Zane and Steve and I have final say over who we collaborate with. I've never heard Zane or Steve to say no to a single person to collaborate, never once. So pretty much anyone who asks us if we can do it, we try and do it. And it just depends on whether we had someone approach us recently about Peutz-Jeghers, and they need fresh frozen, and we don't have a lot of fresh frozen from Peutz-Jeghers patients. So those kind of things we'll say if we can't do it, but often we can help just about anyone who has a study that wants to work with us.
I have a question, if you have a minute. This is Priyanka Kant. I'm from Georgetown University. Melissa, is it possible, I'm trying to do the same thing, develop a registry here, like a foundation. Is it possible to you have a very nice template. Is it possible that we can talk to you and see what template you've used and use the similar here while we are just putting in things together?
Yeah, it's all done by our IT. We have IT people that work with the center, so I could put you in touch with them, and they could, I'm sure, tell you what they use and how they did it.
Perfect. Thank you.
Mm-hmm.
I mean, Melissa, you should tell them to sell that or share it even better. But I think I agree with Bianca's statement. I mean, that looks perfect, and that's what we're all kind of looking for, is not have to, create it over and over. So
I didn't show you, we also have links to like the records. We have a whole electronic like data system where we keep their actual path report, so we can at a click of a button just go get what we need. It's really nice. Yeah, they've done amazing work.
Well, I think we're at the top of the hour here. We are seconds from concluding. I want to thank all our fabulous speakers for their time, and to Evelyn Tubovilla, who's behind the scenes, and Rachel Hoden, who approved this in the first place and supported us doing. Thank you all for the participation, and look forward to seeing you at CGA and elsewhere.